All righty, we're going to go ahead and get started. Today we're talking about NSAIDs, which, when, and how much. This is one of my newest talks. This is a slide set, a presentation that I created last year. And so this is actually the second time I'm going to be presenting this. I think this is a really important topic and something that we maybe don't talk enough about is pharmacology. We deal a lot in family medicine. We deal a lot with medications, a ton of different classes of medications. Some of it we kind of jokingly rib some of our colleagues who maybe go into fellowship in sports medicine that all they really need to remember is NSAIDs and steroids. But as family doctors, we learn and actively use so many classes of medications, and I think we often fail to talk about what those medications do, or maybe we talk about what they do, but we fail to talk about the side effects and how often we see side effects and interactions. And so today I want to take us through a discussion about NSAIDs, kind of a class of medications that we use a lot. Whether you want to or not, you're going to have patients who are taking them. And that's the other thing unique is obviously these are medicines that are available over the counter. So let's talk through that, and I'm going to build this discussion around a case. Today we're going to be presenting on the case of Mr. Jones, 63-year-old male presenting to your office with chronic joint pain, mainly in the hips and knees. And he has tried over-the-counter acetaminophen, naproxen, and ibuprofen, and these are just providing minimal relief. It's starting to affect his day-to-day activities. And you perform a history and an exam, and you either order or you maybe already have x-rays that are consistent with osteoarthritis. So that is our case. And I want to know at this point, what questions do you have for Mr. Jones? What additional information would you like about Mr. Jones related to your decision making today? How are you going to manage this individual? Okay, so Dr. Rainey wants to know, how long have you been taking the medications, like each of the medications that you've tried? It's a good question. And what doses? Yes. Ooh, good question. Dr. Ernstberger wants to know if the patient, if Mr. Jones has any history of gastric ulcer disease or heart disease or kidney disease. Very good questions.
What is his BMI and is he exercising?
Yeah, what is his BMI and is he exercising? So it sounds to me like you're getting at some cardiovascular risk factors there. Yeah. Yeah. So what is his job, and how is his current symptomatology affecting his function in his job and perhaps in other areas of his life? Good. All right. Anything else? Otherwise, we'll move along. Okay. We're going to come back to Mr. Jones at the end of the talk today, but I am going to go ahead and move along. We're going to talk a little bit more about NSAIDs in particular, and this slide is the case for NSAIDs. Dr. Sir William Osler is quoted to say, "This is our work, to prevent disease, to relieve suffering, and to heal the sick." I guess when it comes to NSAIDs, we're probably looking more at the healing, or relieving suffering aspect. We know that NSAIDs reduce pain and inflammation for numerous acute and chronic conditions. This has been studied over many, many years. Opioid pain relievers are one of the few other options, and we know that those are far more dangerous. And we've seen in recent years this growing opioid epidemic, and a 2018 study in particular conducted by the CDC shows that 128 people die due to overdosing on opioids in a single day in the US. And of course, that That's going to vary, and that data is going to change over time, but that's pretty significant, pretty powerful. Other options and alternatives are few and far between. Acetaminophen, but may not be effective for every patient. So what about the case against NSAIDs? Well, these medicines do come with a price. They carry some serious and for some patients even fatal gastrointestinal bleeding events. In fact, up to roughly a third of elderly fatal peptic ulcer complications are thought to be due to NSAIDs. It is the highest in terms of elderly patients succumbing to a fatal peptic ulcer. It is the #1 medication cause. NSAIDs have also been implicated in elevated risk of MI and cardiovascular harms. And NSAIDs may contribute to polypharmacy. And in fact, some patients may even take both prescribed NSAIDs as well as over-the-counter NSAIDs. So there are some reasons for pause. But whether you're for them or against them, the truth of the matter is NSAIDs are everywhere. And they are among the most prescribed medications globally. And some have found this in 2 different studies that are referenced from 2 different studies, that about 5 to 10% of all medications prescribed globally are NSAIDs. That's pretty astounding if you think about the vast diversity of medications that we have available. 2009 CDC survey of US doctors, basically ambulatory practices, found that analgesics were the most commonly prescribed medication, whether it be a new prescription or a continued medication, at a rate of about 11.4%. So that's not specific to NSAIDs, but we do provide a lot of analgesics. And again, the over-the-counter NSAID thing. So what are NSAIDs and where do they come from, and how long have they been around? This is a slide that I put together a little timeline for you. Interestingly, Hippocrates wrote about the effects of willow bark as early as 500 BC. So they've been on the radar for a long time. Salicylate was first isolated from willow bark in sometime in the 1830s. And then aspirin was discovered by a gentleman working for Bayer in Germany, discovered aspirin, which is specifically acetylsalicylate. And that was discovered in 1897. So aspirin has been around for 100 years and even more. Now, most of the NSAIDs that we talk about in typical practice, like ibuprofen and all the other NSAIDs that you think about, basically are a product of the 1960s onward, most of them in the 1960s. MELOXICAM came along in 1980, and CELECOXIB is really our newest NSAID, as far as oral NSAIDs at least, and that one came along in 1995. So there are multiple NSAID classes. All of them have one thing in common: they block cyclooxygenase. Now, there are a couple of different cyclooxygenase receptors, and the NSAIDs do vary in their affinity for COX-1 versus COX-2, and that is going to lead into some of the differences when we talk about prescribing NSAIDs and would you want to use this one or that one. That's going to lead into some of that discussion. So these agents do vary quite a lot in their mechanism of action, their toxicities, their pharmacokinetics, etc. This slide is just to kind of highlight how really different these are. If you look at them chemically, you can kind of compare the chemical structure. Aspirin's pretty simple, one benzene ring with a couple of attachments to it. But some of these medications are quite a bit different, quite a bit more complex. You can see that really not one looks a lot like another. And so chemically, they're going to have different effects within the body. So the NSAIDs originally have been organized as their structure, according to their structure. What you're seeing here, this chemical structure, if you think like a chemist, you're going to say, well, we're going to lump the ones that have a anthracyclic ring, or the ones that have an acetic acid derivative. We're going to link those. And so that's what you get here. when you look at these sort of boxes that show different structural classes of NSAIDs. This conveys a little bit of utility in the sense that if a patient doesn't respond to one that's, say, an acetic acid derivative in the copper box, they might respond better to an enolic acid derivative in one of the other, well, sorry, the other copper box. So you can sort of pick one from this class, and if that doesn't work, you can pick one from a different class. There's some utility in that thought. However, more recently, with the advent of the COX-2 selective NSAIDs, or NSAID, there's some thought about organizing or categorizing NSAIDs based on their COX selectivity, whether they're going more for COX-1 versus COX-2. This is a somewhat helpful graphic. As you can see, Toradol, our KETOROLAC, our injectable NSAID, is highly COX-1 specific, and CELECOXIB on the other end of the spectrum is highly COX-2 specific. You've got some NSAIDs that fall in the middle. Naproxen and ibuprofen are pretty close to the middle. And we'll talk a little bit more about that. So there's a couple of important things that underlie the pharmacology of NSAIDs that you should remember. One is that there is a ceiling effect for the analgesic effect of NSAIDs, but not to the anti-inflammatory effect so much. But the analgesic effect, there is a ceiling amount. So that you hit a certain dose, you're not going to get any further pain reduction. NSAIDs in comparative studies do tend to be more effective than acetaminophen for pain that's associated with prostaglandin-mediated activity. So remember that when we talk about pain, especially in the sense of chronic pain, what type of pain is that? Is that neuropathic? Is that nociceptive? Is that inflammatory? And within inflammatory, of course, there's a couple different categories, but in particular, the pain that's caused by prostaglandin-mediated activity. And so a couple of examples of that would be osteoarthritis, such as our case, Mr. Jones, and dysmenorrhea, which Mr. Jones probably does not have. NSAIDs have more adverse effects than acetaminophen. So even though they are on average more effective, they also have more side effects. And those commonly include headache, drowsiness, nausea, and indigestion.
Is drowsiness actually pretty common?
Drowsiness is fairly common, but it is also dose dependent. So if someone takes a couple of ibuprofen over the counter, they may not have much in terms of drowsiness, but if you put them on an 800 milligram or they take a different prescription strength NSAID, they may have a little bit more drowsiness with that. So let's talk about more of the adverse effects of, this is drug-to-drug interactions with NSAIDs, and then we'll come back to the side effects. I think I might have got a slide out of order in there, but there are some drugs that you need to really, this is a list that I would challenge you to memorize and try to remember this thing. I grant you that we don't use a lot of lithium, but I do know that we have patients here within the clinic who are on lithium. I've staffed a couple not so long ago, and NSAIDs may increase the serum concentration of lithium. And you recall lithium has a very narrow therapeutic window. So it's very important to counsel our patients on lithium about the use of NSAIDs and to prevent the prescribing of NSAIDs when we're on lithium. And these are the first four here are D, category D risk, which is the category where we say, yeah, we really need to not use, avoid use, or choose an alternative, or at very least, very close monitoring. Methotrexate, we have patients here with rheumatologic disease, and what do patients with rheumatologic disease often take? A lot of them take methotrexate. What do patients with rheumatologic disease often complain of? They complain of musculoskeletal pain. So keep in mind that patients on methotrexate, it is a risk category D to have them on NSAIDs. And that is because same mechanism with lithium, it can increase the serum concentration of methotrexate. Now, could you take a patient who's taking 7 tablets, what is that, 17.5 milligrams of methotrexate weekly, and say, let's lower you to 4 tablets of methotrexate and then try you on this NSAID? Maybe. I'm not an expert on that, but you definitely need to be careful with concurrent use of those medications. So,
Not that we should rely on this, but you already get these flagged in sooner.
good question. The question from the audience is, would we get a pop-up in Cerner if we co-prescribe these? I do get alerts that pop up. I will fully disclose that sometimes I will try to prescribe something and Cerner will pop up an alert to me. I'm being facetious. I don't look at that as a failure on our part at all. But I don't specifically know if I don't know if that particular combo pops up or not. A good question, and something that I don't know if I'll get to it today, but I'd like to try to look into that. If you get a chance, maybe try to look into that.
I would wonder if that's only with like lithium or something, the rest of that slide.
Don't know the answer there, sorry. Diuretics. So diuretics will increase the nephrotoxic effects of NSAIDs. They'll have additive nephrotoxic effects. Also, interesting thing to note is NSAIDs will decrease the effectiveness of your loop diuretic. So you want to be careful with NSAIDs in the setting of heart failure anyway. But if you have a patient who's relying on loop diuretics to maintain their fluid balance, NSAIDs can really upset that. And this is, be admitting a patient, if you're on night float or inpatient service and you're admitting a patient with heart failure exacerbation, you might want to ask about NSAID usage. SSRIs. We put SSRIs in the water. I mean, many of our patients are on SSRIs, right? And we need to be cognizant of the fact that NSAIDs can decrease the therapeutic benefit of SSRIs. That's a little scary. And they also can increase the additive effect there, can increase bleeding risk. So then these last three are risk C. C is where you want to do careful monitoring. It doesn't mean that you necessarily can't use the two medicines concurrently, but you do want to be very cautious with that. Obviously, anticoagulant and antiplatelets for the bleeding risk, the ACEs and ARBs for renal injury, and corticosteroids, mainly because they're having a lot of the same side effects. Both of those medications are going to be working on prostaglandin. So we talked already about some of the side effects, but GI toxicity, how common really is that? Well, studies show that patients who chronically take NSAIDs, that up to 20% of them will experience ulceration, perforation, or bleeding. That number seems high to me, but I would just say, regardless of what the number is, it is not insignificant. Anemia, increased bleeding time, asthma. About 10% of asthmatics are sensitive to NSAIDs, according to the research that I found. Renal injury, of course, is something we think about often, but remember liver enzymes. I think in medical school, it was sort of conveyed to me that I need to worry about acetaminophen with liver disease and NSAIDs with kidney disease. I want to if any of you, I see some people nodding, because that's what I think I learned, and I see other people nodding. I want you to erase that. I want you to erase that, and let's put a new teaching pearl in there. Acetaminophen is safe in reasonable doses for patients with liver disease. In fact, patients on the liver transplant list can use acetaminophen up to 2 grams. It's a lower limit. So that medicine turns out to be actually quite safe, and it doesn't carry any risk to the kidneys or to the stomach. But what you need to remember from today is that NSAIDs carry risk for both kidney and liver disease. And it's something that you want to be very careful about using in patients with cirrhosis or hepatitis. I wouldn't use it at all in a patient with active hepatitis and even hep C. So CHF, we talked about elevated blood pressure. It is thought that NSAIDs increase blood pressure by about 5 millimeters of mercury on average. Now, that number by itself doesn't sound like a lot, but it may be significant. You all remember the study that came out in the fall of 2019? The cardiologists, I forget the name of the study now, but the cardiologists did this big study about targeting what are the blood pressure targets that we should be trying to hit. And they said, we're going to have an intensive arm that's managed to below 120 on the systolic below 60 on the diastolic versus the usual care. And the intensive arm had a decrease in stroke and cardiovascular endpoints. Now, that's not the purpose of our talk today, but I use that as an illustration to say, if we're raising the blood pressure of our patients by 5 millimeters of mercury, that may be significant. And then cardiovascular risk, I did want to share with you real quick the Vioxx story. Many of you Vioxx has been withdrawn from the market now since 2004. So many of you don't know about Vioxx and maybe have heard of it, but Vioxx was the original COX-2 NSAID. It was the first one that came out. Its brand name is Rifacoxib. It was marketed, it was actually approved by the FDA in 1999. It was marketed by Merck Pharmaceuticals, primarily under the name Vioxx. It became wildly popular because here's a brand new NSAID, first one since probably 1980s. And this one is special because it doesn't cause the ulceration risk. They knew from their studies that it was safer for the gut. And I remember as a medical student, I remember being on rotation when an article came out in American Family Physician about this new COX-2 NSAID class. And people were very excited about it. And it was like, hey, this is the drug to put all your old people on because it is not going to cause them bleeding ulcers. And it took off. In the year before it was pulled from the market, over 80 million people were prescribed the drug. I know, so shocking, Kristen dropped her sushi. 80 million people is a big number. That's worth dropping your sushi. And in 2004, Merck withdrew the drug from the market voluntarily over concerns about increased risk of heart attack and stroke with long-term use. They withdrew the drug following disclosures that they withheld information for over 5 years about that increased risk. And retrospective analysis estimates about 88,000 to as many as maybe 140,000 cases of serious heart disease related to the use of that medication. So this was a really big deal. And the other shoe that dropped sort of was people looking back and saying, well, how much did they make on that drug? 80 million people is a lot of people taking it. In the year before its withdrawal, Merck recorded sales revenue of $2.5 billion with a B dollars from Vioxx. So there are black box warnings on NSAID, prescribed NSAIDs, that there are 2 of them. One says that NSAIDs cause an increased risk of serious and potentially fatal adverse cardiovascular thrombotic events. The other black box warning talks about the increased risk of serious gastrointestinal inflammation, ulceration, bleeding, and perforation, which also may be fatal. So keep this in mind as you are prescribing these medications that, we as doctors are busy. We tend to focus on efficiency and moving through our day and trying to get our documentation done and our notes done. And it's not easy. And we may skip over this conversation, but when you're talking to a patient about starting an NSAID, you really should say, by the way, you need to know this. It's got a black box warning. These medicines can cause really serious harm, even death. And it's hard to have that conversation. I get that. So what is the true cardiovascular risk of NSAIDs? This is a study that was published in BMJ in 2017. It's a meta-analysis, and it showed that all NSAIDs except for aspirin, if you want to lump, aspirin's kind of the stepchild, right? It was the first one, and we don't often think of it as an NSAID. It's kind of its own drug. In some ways it behaves like an NSAID, in some ways it doesn't. So we're not talking about aspirin here. Aspirin, we don't think aspirin causes heart problems. In fact, we use it for that. But all NSAIDs except for aspirin were found to be associated with increased risk of acute MI. Taking any dose of NSAID for a week or more was associated with an increased risk of MI. The risk was greatest during the first month of use, and it's greater with higher doses. So all NSAIDs are implicated in this. Now, this is you're not going to be able to just take this in. I get that. But I'm going to just tell you what this slide is. This slide represents the comparative risk across different NSAIDs. And if you ever want to pull this the slides up and study it, you're welcome to it. But basically what it shows is starting with ibuprofen as sort of like the reference point, that actually they're using naproxen as the reference point. Ibuprofen is greater risk for everything. MI, stroke, CV death. Don't worry about APTC. It stands for antiplatelet trialist collaboration. I don't know why that's in there. I don't know what that means. But it isn't referring to anything medical. So ibuprofen carries more risk than naproxen. So file that away. That's a little pearl. And then as you go down some of these other ones, you can sort of see some that have lower versus higher. CELECOXIB. The CELECOXIB is the third row. It tends to compare, it has a little bit higher risks than naproxen, and it has lower risks than ibuprofen and diclofenac. So you can kind of compare a little bit. I'm going to boil this down for you a little bit in different slides. We talked about the blood pressure thing, and again, estimated increase of an average of about 5 millimeters mercury with non-selective. And this, actually, I need to update the wording on this, but all NSAIDs. GI injury, how does it actually affect the GI tract? Well, inhibition of cyclooxygenase leads to decreased bicarbonate, which increases the acidity of the environment. It also decreases mucosal blood flow. It also decreases epithelial mucus production. So it's actually working 3 different ways against us to injure the gastric mucosa. In fact, the fourth way is it can injure the gastric mucosa directly because the drugs themselves are acidic. So there's several ways that it's working against the gut. How do you combat that? Well, you can try acetaminophen. Sorry, I didn't mean to advance. You can try acetaminophen. You can definitely screen for H. pylori and treat your H. pylori positive patients. In fact, that is a very strong recommendation. It's a strength of recommendation A, which means we should consistently be doing this, guys. And I think I'm guilty of not doing this. I think I'm guilty of not thinking about starting, oh, I got a patient I'm going to start on an NSAID. I need to test them for H. pylori. That has not been a reflexive, instinctive thought that it needs to be. So we need to develop that, guys and gals. Add a PPI for patients at risk, or misoprostol, or switch to the COX-2 Celebrex, CELECOXIB. So again, just to highlight these recommendations, physicians should perform lab screening for H. pylori and eradicate H. pylori before initiating long-term NSAID therapy in patients who are not on NSAIDs. And these are people who have not had peptic ulcer disease. This is just to reduce the risk of peptic ulcer disease. Physicians should screen for and eradicate H. pylori before initiating long-term NSAIDs in patients with a history of peptic ulcers. So that sounds a little redundant, but the reason for the second line is people get peptic ulcers for other reasons, and maybe they had a peptic ulcer 5 years ago and they tested negative, but you should test them for H. pylori before starting NSAIDs. Question?
Dr. Whitt, and maybe, I'm sorry if you mentioned this before, but the definition of long-term NSAID therapy.
Yeah.
I get so caught up in that detail.
Sure. Question about where do you define long-term NSAID therapy? That's a good question. I honestly didn't read anything in what all of them. I mean, I pulled about 30 articles for this, and I don't remember any of them saying anything about what's chronic versus what's acute. I tend to think about chronic as being 3 months or more. And I do think in the opioid literature, they talk about chronic opioid use being 3 months or more, if I'm remembering that correctly. So that's kind of where I would think probably. But going back to that heart risk study, even taking NSAIDs for 1 week, they showed an increased risk of MI. So back to, yes, GI toxicity. So some are worse than others, right? We already said CELECOXIB is COX-2 specific. It's better for the gut, and that is true. There are other NSAIDs that are a little bit comparatively better for the gut, and I'm going to highlight MELOXICAM in particular. MELOXICAM is an NSAID that is COX-2 specific at low doses, and as you increase the dose, it becomes more COX-1 specific. I think MELOXICAM is a very useful drug, and I have prescribed it. This is one of my kind of, I've got about 5 go-to NSAIDs, and this is one of mine, but MELOXICAM is something that you can use in low dose, and it is COX-2 specific and lower risk for the gut. Some of your worst offenders, that includes KETOROLAC, which anybody remember prescribing Toradol, KETOROLAC? What's unique about prescribing that, besides the fact that it's an injectable? It's also an oral, by the way. What else is unique? When we prescribe Toradol, what do we do prescribing that? That's different.
When you say on dosage, the length of time.
The length.
Keep it till 5 days.
We keep it to 5 days, don't we? Yes. And why do we keep it to 5 days? Because of this. Because it is so COX-1. Remember when we showed the graph that had it all the way to the one side? It is so COX-1 specific. It is hard on the gut, and especially oral. Taking it more than 5 days can cause an ulceration. So CELECOXIB is the only NSAID currently marketed, that should say marketed, as COX-2 specific. And it may also be a little safer in terms of antiplatelet drug interaction. And obviously less GI risk and maybe less renal risk. However, it is one of the weakest NSAIDs in terms of pain control. It is one that has the lowest effectiveness in terms of getting the patient's pain controlled. To put some numbers to that, one study showed only 40% of patients treated with CELECOXIB 200 milligrams a day. That's not the highest dose, but that is kind of the good normal working dose. Only 40% reporting at least minimal clinical improvement. And comparative to naproxen, that number was 78%. So keep that in mind. If you've got someone that's high risk, it's still a good option to try, but it may not work. It doesn't work in every case. I've already talked about meloxicam. It is more COX-2 specific. And again, that dose of 5 or 7.5, that's where you get the COX-2. In fact, it's a 10-to-1 ratio. It tends to go after COX-2 10 times more, but at higher doses, like 15 milligrams, it has a greater effect on COX-1. This one used to be expensive, but it is now priced friendly at about 3 to, it depends on, like if you look up GoodRx, some of them are higher, but it's around, you get it for like $3 to $5 a month. So,
You mean the COX at higher doses, COX-1 starts to catch up to COX-2 or actually
so the question is, as you raise the dose of meloxicam, does the affinity for COX-2 increase to meet the affinity for COX-1, or does it switch?
Like, does it turn into Toradol?
Does it turn into Toradol? I think it's more about balance.
Okay.
Yeah. I don't know that I've read specifically exactly the answer to your question, but my sense is it's more of a gradual shift toward an affinity for both COX-1 and COX-2. So this is a what do you call this? Well, it looks like an algorithm, but it's really more of a pick. How do you pick which NSAID you want? And this was published in let's see, where was this published? The Journal of PM&R. So if we ask our physical medicine colleagues about this, they've done some research and some reviews, and they suggest for patients with musculoskeletal pain, those who have low GI risk and low CV risk, you can use any NSAID. There's no contraindication. I mean, obviously they're not talking about renal, maybe the patient has a renal contraindication. We're not saying that, but just in terms of the GI and cardiovascular, if they're not at risk, you can use any NSAID. If they're high GI, but low cardiovascular, you can try to maybe steer them towards CELECOXIB or MELOXICAM, because those are going to be lower risk for the gut, not necessarily the heart. You also might want to consider adding a PPI. And we talk a lot about polypharmacy, and my goal here today is not to drive up polypharmacy, but it's a consideration you want to at least think about adding a PPI in those high-risk patients or avoiding an NSAID. And try to avoid non-selective NSAIDs in those patients. The middle column is high cardiovascular risk, but low GI risk. In that case, you may want to use the NSAIDs that have a lower risk of cardiovascular, and that tends to be naproxen and CELECOXIB. So that goes back to that big study we showed with all the little crazy graphs comparing NSAIDs to each other. Now, naproxen tends to interfere with the protective benefits of aspirin. So if they're taking aspirin daily because of their CV risk, and you put them on naproxen, that lowers the benefit of the aspirin. So CELECOXIB tends to do that less. So that's where CELECOXIB also has a unique niche, is there on the patients with high cardiovascular risk, but who are also taking daily aspirin. Now, ironically, the other COX-2, that first one that came out, Vioxx, that we talked about, that had a much elevated cardiovascular risk. So just the fact that Celebrex is COX-2 doesn't mean that's why it's safer for the heart. Vioxx was shown to be worse in terms of cardiovascular risk. For your patients with both high cardiovascular and high GI risk, probably should avoid NSAIDs. And definitely in patients with heart failure, recent bypass, or advanced renal disease, as you, I'm sure, well know, you want to avoid NSAIDs. So I think this is helpful. Yes, Kristen.
Another detail, the recent cabbage, I had a patient with a stent maybe 5 years ago. Has arthritis. Really hesitant to take any ibuprofen, but that does help.
Yeah.
So, what would you recommend there?
Okay, question was, what about where it says recent cabbage? What if, how recent is recent? Is that like last week, or is it 6 months ago? What about a patient who had stents or a cabbage 5 years ago? What is the risk like for them? And that's a good individual, values-based discussion with your patient for sure. But to give you a place to start with that, I would say, based on my reading and my sort of study of this issue, I would say that obviously as time goes out from an MI, as time goes out, that there is somewhat lower risk of a second MI. Not in every patient, not in every case, but we do have this sort of imminent, I guess I think of it this way. A patient has a cabbage or they have a stent, we put them on dual antiplatelet. Studies show that if we keep them on that for 12 months, it improves outcomes. So if we add on naproxen to them 5 months in, and they're on their dual antiplatelet, that includes aspirin. Now we're reducing the effectiveness of aspirin. So I would be reticent to add an NSAID in that first 12 months following a cardiovascular event. And that's mainly based on that line of thinking. So I can't say that this is evidence-based recommendation, but I would be reticent to add an NSAID in that first 12 months. As time goes out, if I have a patient that's 5 years out from an MI, granted, not all of them have changed their lifestyle, but some of them, they're eating better. We've now got them on a statin. It's been 5 years, they've not had a heart attack. I still consider them to have vascular disease. And they still have the risks, but I would maybe consider, a trial of naproxen if they're not taking aspirin, or CELECOXIB if they are taking aspirin, might be a reasonable thing. But would certainly want to document it in the patient's record that you had a discussion regarding the risks and benefits. Here's some info about costs. Just to kind of give you an idea, most of these are pretty cheap now. Even Celebrex, the newest one, has been out since '95, and you can get generic CELECOXIB, and it's as cheap as $6 a month. Diclofenac gel, that one used to be really expensive, right? Voltaren gel, now it's over the counter. And I pulled up, maybe I forgot to, oh, I have it in a separate slide. We'll come back to that a little bit. So special circumstances, I did want to touch on KETOROLAC a little bit more. KETOROLAC is the injectable NSAID. It's the one that can be given IM or IV. By the way, studies don't show any benefit of IM over IV. They're equal, equivalent. You can give it IM or IV. Obviously, the big drawback is whether you're giving them a shot, causing them some pain or not. We talked about use limited to 5 days. And here's oh, by the way, nausea, headache are reported more than 10% of patients in one study. That's pretty high. So 1 in 10 or more have nausea and headache. Might want to just warn your patient, I guess, if you're in the ED, you're going to give them Toradol or whatever. Here's the thing I want you to take home about KETOROLAC is less is more. Remember we talked about how NSAIDs, they have a ceiling effect for analgesia. You can get to a certain amount of analgesic relief, but you keep going up on the dose, it doesn't matter. Toradol's like that, and it turns out that the ceiling effect comes in around 10 milligrams of Toradol. So what you will see if you look up in, let's say you pull up Hippocrates right now, I'm getting ready to dose Toradol, how do I dose that? You pull it up in Hippocrates, it's going to tell you 60 milligrams IM times 1. It's going to tell you that you can do 30 milligrams every 6 hours, at least for younger patients, lower than 65. But I'm telling you, you probably do not need that high a dose, and you probably do not benefit from that high a dose, your patients either. The FDA label allows you to go up to 120 milligrams per day. But the study here, this was published in the Journal of Family Practice. And if you don't read the Journal of Family Practice, you should try to look at this pearls section in there at the very least, because those are really good. And this was published in there in January, February issue 2019. And they said, based in this study of 240 adult patients presenting to the emergency department, that they received either 10, 15, or 30 of KETOROLAC, and they all received it IV. And they found that the baseline pain scores were similar for all groups, and all 3 doses of KETOROLAC decreased pain significantly at 30 minutes, but there was no difference between the groups. And there was no difference in the number of patients who needed rescue medication at 30 minutes between any of those groups. So their conclusion from that study was 10 is just as effective as 30. Now, here's the problem with that. You can't order 10 milligrams of IV Toradol. That's a little frustrating, but you can't. You can order 15 though. If you pull up Cerner and you order KETOROLAC, you've got 15, 30, and I think there's like a 60 times 1 order in there, but I'm saying choose 15. Topical, we touched on this a little bit. Topical NSAIDs are more effective than placebo for acute pain. These are good drugs to use now, and the incidence of local and adverse effects is basically that of placebo. Diclofenac gel is over the counter, widely available. A quick price search suggests that you might want to go to Walmart or Target for the best prices. Just your friendly public service announcement. Just remember, if you're prescribing for some reason, honestly, I don't know why I would prescribe it at this point, but if you're prescribing it, don't prescribe the 3% because that is for treatment of actinic keratosis. You know, it probably says on it, not intended for use on humans, but I can't read that from. Yeah. Yeah, I like that. I saw that too. Pregnancy, what about pregnancy? Well, these are likely safe in breastfeeding women, strength of recommendation C. NSAIDs are not known to be teratogenic in humans, and they are generally considered safe in pregnancy in low doses and with intermittent use, but we avoid them in the last 6 to 8 weeks before term due to effects on the fetal ductus arteriosus. And so we're cautious about NSAIDs in pregnancy. They're probably fine to use in breastfeeding women. And low-dose aspirin, of course, which we're sort of including in this talk, is considered safe throughout pregnancy and is now recommended for prevention of preeclampsia. And lastly, I'm going to finish up with COVID, a couple slides on COVID and NSAIDs. This slide I left in there from last year to say that early reports based on expert opinion recommended not to use NSAIDs in patients with COVID-19. And this was based on this particular study here was from the UK. And they said that we can't find any evidence to suggest whether acute use of NSAIDs is related to increased risk of either developing COVID-19 or increased risk of more severe illness. But they basically said, yeah, maybe it's best to not use them. But as more data have emerged, there is less concern on this. So I included 2 studies here, a Danish population cohort study with about 9,000 positive SARS patients. Now, I think these were outpatients. I think these were people who were just tested positive for SARS-CoV-2 by PCR, and they compared those that used NSAIDs or non versus non. The use of NSAIDs was not associated with any of these things: 30-day mortality, hospitalization, ICU, ventilation, or need for dialysis. No association with any of those things. They said it does not matter. And a second, a similar study, there was actually a pair of studies done by the same authors in England, also population-based cohort studies, combined over 700,000 current NSAID users. So this looked at it from the other angle. What if you're a user, an NSAID user, are you more at risk of COVID related death? And they said no, there was no association. So we're going to close back on Mr. Jones. We've seen Mr. Jones. Remember, he's 63 years old, came in with complaints of knee and hip pain related to osteoarthritis. We asked him about GI and cardiovascular risk, and we found that he has no contraindications to NSAIDs, and he's kind of someone with an average cardiovascular risk. So we decided that we would test him for H. pylori, right? Because we learned today that we should be testing these people for H. pylori before we start an NSAID, and he's negative. Great. So then we're going to try, maybe let's do a trial of meloxicam 7.5 milligrams daily with regular exercise. Why prescribe regular exercise? Because it helps osteoarthritis. And that's their ancillary treatment. And why meloxicam? Well, he's 63. He doesn't have H. pylori, but he's probably low GI risk based on what I'm saying here, and low cardiovascular risk. So we could use any NSAID. But he is 63, so you know, with him being a little bit older, maybe we'll choose this sort of low to medium dose of meloxicam first and see how he does on that. I would not have a problem with putting him on naproxen. You know, if no GI bleeding history and H. pylori negative, we could potentially use any NSAID. See him back when? I would see him back in a month. You know, you could see him back a little sooner, but make sure that you're following up with him and how's he doing. So to summarize, I avoid certain NSAIDs. I didn't specifically call these out, but I will call them out here as I just don't use indomethacin anymore. It's funny because some people kind of go to that one for gout treatment because the early studies with treating gout used indomethacin, and I don't care. I just give them naproxen, use something. I just don't tend to use that one anymore. You can see the list there. I just don't tend to use those things. Let's see, mefenamic acid, I actually do use that for menstrual PMDD, or that's not exactly what I want, you know what I mean. Like problem with menses, I will use mefenamic acid. I generally use over-the-counter naproxen or ibuprofen in low-risk patients and recommend over-the-counter use if they want to. I always try to remember to stress to them the max dose because people sometimes think if 2 is good, then 4 is always better, or maybe 6 will be even better. And try to stress the right doses. Cautious use of naproxen in patients with cardiovascular risk factors, but try to remember to document that discussion. And then I try to maintain familiarity with kind of like 4 or 5 different NSAIDs, one from each class sort of a thing, just to give me a few choices. And those are my go-tos, tend to be like ibuprofen, naproxen, in particular, meloxicam and CELECOXIB, and then sort of a distant fifth is nambumetone. It's in a different class. Plus the topical, I'm trying to use more and more topical like Lofenac. And then IV KETOROLAC in the hospital setting, generally, sometimes for migraine treatment in the outpatient setting. So bottom line, select appropriate patients for NSAID use based on their risk factors, prescribe the lowest dose and the shortest duration, use topical when possible, screen for H. pylori. That's probably the biggest practice changer that needs to come out of today's talk, and regularly monitor for adverse effects. That is it. That's all I got. I'll try to answer questions. You all have been doing a good job of asking those as we go along, so maybe we don't have a lot of additional questions at this point.
Dr. Whitt, do you know what the therapeutic ceiling, would that prepare for ibuprofen? I know a lot of
Good question. The max dosage is 800 milligrams per dose and 3,200 milligrams per day. Sorry, I'm having some technical troubles. Anyway, the maximum dosage is 800 per dose or 3,200 per day. Good question, Tobin, where do you get that max analgesic effect? And I think, honestly, the study hasn't been done. You know, they did the study in the ED setting with Toradol, and they found that the analgesic effect probably comes in about 10 milligrams. It would be really interesting to do that study with ibuprofen. I just don't think it's been done. I don't know.
I think there was evidence that the 400 or 600 milligram dose.
Yeah. I will say anecdotally, I think it's been a long time since I prescribed 800s, and I tend to give people like 600s if I am prescribing it, ibuprofen. Yeah, Dr. Bunch was just sharing from the audience that there is good evidence for synergistic effects with using acetaminophen along with an NSAID, such as using acetaminophen dose along with ibuprofen. Dr. E.
I've also got a patient that gets oral TOXICITY for migraine oral therapy. As long as you're really looked at about telling them not, use it more than the appropriate. one patient that swears by oral ketorolac at the time.
Yeah, so Dr. E was sharing he has one patient with chronic migraine who just swears by oral ketorolac. And as long as we're monitoring the usage carefully, that's a reasonable option. And I would agree. Okay, well, we are after 1 o'clock and I'm not seeing any other questions.